Welcome to the Medical University of South Carolina. What's a kidney transplant biopsy? Kidney transplant biopsy is performed to obtain a tissue sample from your kidney transplant. That tissue will be examined by a pathologist under a microscope to get a closer look at the structure of the kidney. Why do we do a biopsy? We perform a kidney transplant biopsy for a variety of reasons. Primarily, we're looking to diagnose the type of kidney injury. One of the causes is rejection. This means your body immune system has figured out that there is an intruder and is trying to fight it off. We also look for other possible injuries, including recurrence of native kidney disease, infection of the graft, and the amount of viable tissue in the graft. By biopsying the kidney, we can diagnose the cause of kidney injury and determine the appropriate treatment. What does a biopsy entail? Before your kidney biopsy, you will meet with your doctor to talk about what to expect. This is a good time to ask questions about the procedure and make sure you understand the benefits and risks. Your doctor or nurse will let you know when and what to stop taking certain medications and supplements and for how long. Examples are aspirin, Plavix, or other blood thinners. These medications are usually stopped 5 days before the procedure and then started again 5 days after the procedure. You may be asked not to drink or eat for 8 hours before the kidney biopsy. During the procedure, we will be using an ultrasound to help to guide our biopsy. When you first arrive in the room, we will have you lay flat and lift your gown to expose your abdomen. This is how the room setup will roughly look like. Using the ultrasound probe, we will look for a good view of your kidney transplant where we can safely biopsy. Once we find a safe view to perform the biopsy, we will sterilize your abdomen with a small medicated sponge. You will then receive the numbing medicine injected into your abdomen. This is meant to numb the path that the biopsy needle is about to take, ensuring that you feel no pain. You may feel a burning sensation when the local anesthetic is given, and you may feel pressure once the biopsy needle itself is inserted, but you should never feel pain. After numbing your abdomen, we make a small incision in the skin and pass the biopsy needle through. Using the ultrasound to guide our needle, we'll slowly advance to the kidney and obtain a sample. You will hear a click sound when the tissue is obtained. A pathologist will be in the room to determine if we need a second tissue sample or if the first sample was adequate. Afterwards, we will hold pressure for 10 minutes. A repeat ultrasound is performed to make sure that there is no bleeding, and then we're done. You'll stay in the recovery area for approximately 2 to 4 hours on bed rest. Following the procedure, you're advised not to lift anything heavy for 2 weeks. Take it easy and avoid exerting yourself. What are the risks of a kidney transplant biopsy? Bleeding is the biggest risk. This is why we make sure your blood pressure is well controlled prior to the procedure and you stop all blood thinners. You may notice blood in your urine following the biopsy. This is not uncommon, but it should lessen each time you urinate. Soreness or pain are other possible side effects. These should be mild and improve in hours following your biopsy. Infection is also a risk of this procedure. This is why we use sterile technique to minimize exposure to pathogens. If the bleeding or pain worsens, call your transplant coordinator immediately or go to the nearest emergency room. Under certain circumstances, we seek interventional radiology for a CT-guided biopsy. Few examples include when part of the small bowel is overlying the kidney, as the risk of accidentally poking the bowel is too great. Another scenario, if a bleed has developed after the ultrasound-guided biopsy within or around your kidney. Interventional radiology will be called to emergently embolize or zap the bleeding vessel or the arteriovenous fistula formed within the kidney. As a side note, bleeding might subside completely after a kidney biopsy but starts to appear few hours to days later. If this happens, call your transplant coordinator immediately or go to the nearest emergency department, as this may be a sign that an arteriovenous fistula has developed within the kidney and needs attention. Cytomegalovirus, or CMV, is an enveloped double-stranded DNA virus. It belongs to the Herpesviridae family and is one of the most common viruses that causes severe infection in organ transplant recipients. CMV can be transmitted through an infected person's blood and other bodily fluids such as saliva, genital secretions, and urine, as well as through the transplanted organ itself. During primary infection, the virus usually invades and multiplies in epithelial cells such as those found in the oral, gastrointestinal, or urinary mucosa. During the post-transplantation period, the recipient is usually given immunosuppressive medication to prevent the recipient's immune system from recognizing the transplanted tissue as foreign and rejecting it. However, one significant disadvantage of this approach is that the weakened immune system is unable to protect the body from pathogens such as CMV. When the immune system is weakened, the dormant virus takes the opportunity, hence called opportunistic infection, and can reactivate and cause disease. CMV destroys the structure of the infected cells. This causes enlarged cells with intranuclear violet inclusion bodies, giving the appearance of an owl's eye. CMV also infects blood monocytes and establishes a latent infection, which means the virus remains dormant for a long period of time. CMV has the potential to affect nearly every organ in the body. Symptoms vary according to the affected organ, including encephalitis with altered mental status, seizures and weakness, retinitis with blurring of vision, dark spots in the visual fields called scotomas, or even total blindness, pneumonia with cough and shortness of breath, hepatitis with jaundice and liver failure, gastroenteritis with diarrhea, nausea, vomiting, and abdominal pain, and of course, transplant rejection. Very prominent and important alarms to watch for including diarrhea, abdominal pain, and leukopenia, which is low white count. Manifestations usually appear 1 to 6 months after discontinuation of prophylaxis post-transplant. Almost always, the transplanted organ is harmed. This is because virally infected cells attract immune cells to the site, which recognize the foreign transplanted cells and may attack them in the process of killing the virus. What's the risk status? A high-risk status indicates that the donor has been exposed to the virus and has antibodies to it, whereas the recipient has never been exposed to the virus and has no antibodies to it. We keep these patients on antiviral prophylaxis, which is Valcide, for 6 months post-transplant. If the recipient and donor were not previously exposed to the virus, this is called low-risk status. If the recipient was previously exposed to the virus, regardless of the donor, this is called a moderate risk status. We keep antiviral prophylaxis, Valcide, for those patients for about 3 months post-transplant. Few more definitions to know. CMV viremia is detection of the virus in the blood by a technique called PCR, or polymerase chain reaction. CMV syndrome means fever more than 38 degrees Celsius for at least 2 days within a 4-day period, CMV viremia, and either low white count, which is neutropenia, or low platelet count, which is thrombocytopenia. CMV disease consists of end organ disease and CMV syndrome. Infected patients may have low-level viremia, which is viral count in the blood, but have CMV disease with organ affection. CMV infections are diagnosed by isolating the virus from the blood sample using a test called CMV plasma PCR, or from body fluids or tissues using a biopsy, example colon biopsy. Treatment consists of antiviral medications in various doses, such as intravenous ganciclovir, PO valganciclovir, intravenous foscarnet for CMV resistance, PO maribavir, and cytogam, which is intravenous immunoglobulin specifically directed against CMV. Tacrolimus, the generic name, is the cornerstone anti-rejection drug for patients after transplant, providing the most protection from transplant rejection. Patients will take this medication most commonly in the form of long-acting, 24 hours duration, or short-acting, 12 hours duration, as part of their immunosuppression regimen. While it does its job very well, it's a double-edged sword that we must closely monitor. What does that mean? It can be toxic to the kidneys, causing neurological symptoms, make blood sugar difficult to control, and cause abnormalities with minerals and acids in the bloodstream. As you can see, it's a balancing act to make sure that there is enough tacrolimus to prevent rejection, but not so much to cause problems. For this reason, we must monitor the level of tacrolimus in the bloodstream regularly and adjust each patient's dose accordingly. When your transplant provider checks your tacrolimus level, they are looking for a trough level. What's a trough level? Think about a wave with peaks and valleys. The amount of tacrolimus in the bloodstream follows this pattern. When you take tacrolimus, your body absorbs the medication, causing the amount in your bloodstream to rise. Throughout the day, the tacrolimus is broken down and used by your body, causing the amount in your bloodstream to decrease. As such, the level peaks shortly after taking your medication, then hits a low point, which we call a trough level, before your next dose is due. Your provider uses this trough level to decide if you need to increase, decrease, or continue with the same dose of tacrolimus. This is why it is important to take your tacrolimus dose at the same time every day and to have labs drawn just before your next dose is due. If the labs are drawn too early or too late, it's not a true trough and your provider cannot accurately determine how much tacrolimus you need. Let's give some examples. Johnny takes his long-acting tacrolimus every 24 hours at 8 a.m. every morning. He remembered to wait to take his long-acting tacrolimus until after labs, but he does not arrive at the lab until 11 a.m. for his lab draw. His tacrolimus level will be 27 hours after his last long-acting tacrolimus dose. This means it will not be a true trough and the level will likely seem lower than it actually is. Susie does the opposite. She takes her short-acting tacrolimus every 12 hours at 11 a.m. and 11 p.m., but arrives at the lab for blood draw at 8 a.m. before work. This tacrolimus level will be 9 hours since she last took her short-acting tacrolimus dose. Her level will not be a true trough either, and it will likely seem higher in the bloodstream than it actually is. So, does it matter what time you take your tacrolimus? No, you can decide to take your tacrolimus at whatever time works best for you. What matters is that you take it at the same time every day and have your level checked just before your next dose is due. Finally, for the long-acting tacrolimus, make sure to take it on an empty stomach 1 hour before or 2 hours after meals. Dogs? No way, not that one. Parvovirus that affects dogs is not the same as a human Parvo B19 virus. Parvo of dogs is different and cannot be passed from dogs to humans. We will talk today about the virus that affects humans, the Parvo B19. It was first discovered in 1974 while testing blood units for hepatitis B virus in asymptomatic donors. The name originates from the coding of a serum sample number 19 in panel B that gave anomalous results. It was first linked to clinical disease in 1981 and in transplant patients in 1986. Let's give the story a listen. Throughout Petra's pregnancy, all of her friends came to see her at home. One of them sneezed in her face, infecting her with the Parvo B19's virus, which is the smallest, single-stranded, naked, non-enveloped DNA virus. Petra, the mom, later developed chronic arthritis from the virus in her small joints, and that was it. If this happened early in pregnancy, her baby could have developed hydrops fetalis or suffered a miscarriage. Fortunately, she was in her 3rd trimester, and the pregnancy was uneventful. Paula, her baby, grew up and started kindergarten. Paris, Paula's friend in the kindergarten, sneezed in her face and transmitted the Parvo B19 virus to her. Paula began to experience flu-like symptoms. A week later, she developed a rash on her face that looked like someone had slapped her on the cheek, and the rash spread to her entire body. Parvovirus B19 is also known as the 5th disease. The virus travels through the blood, which is the viremia phase, and resides in the bone marrow precursor red blood cells, where it arrests and destructs them. Therefore, it causes aplastic anemia with a low reticulocyte count. The rash with arthritis and arthralgia are caused by the killing phase of the precursor red blood cells. As a side note, remember, the first disease is measles, the second is rubella, the third is chickenpox, and the fourth is roseola. Up till now, there is no vaccine available for disease number 4 and 5, roseola and parvo. Clinical presentation of parvovirus B19 is wide. As previously mentioned, it resides in the bone marrow precursor red blood cells and may be completely asymptomatic. Patients with sickle cell anemia, hematological disorders, and immunocompromised patients, including transplant recipients, may develop significant red cell precursor destruction, resulting in erythropoietin-resistant aplastic anemia, low white blood cell count, and low platelets. Furthermore, the viral infection can result in chronic arthritis, arthralgia, hepatitis, which is liver inflammation, neurological side effects, myocarditis, and most importantly, kidney graft dysfunction, ranging from protein in urine to failure. In transplant patients, the parvo B19 virus may be donor-derived, which means it is transmitted with a transplanted kidney, so keep an eye out if the donor was seropositive, IgG positive, and the patient was heavily immunosuppressed. How do we make a diagnosis? If there is a clinical suspicion, check parvo B19 plasma PCR in transplant patients. A bone marrow biopsy is almost never required. The key is to have a good clinical sense: resistant anemia, arthritis, myocarditis, and graft dysfunction. How do we handle a positive result? Simply let the patient's immune system handle it. Reduce their immunosuppressive medicine, cut the MMF dose by half or discontinue it entirely depending on the clinical severity. You can also give your transplant patients extra immunity by giving them IVIG. Typical dose is 0.4 gram per kg times 5 doses. You can give it weekly or every other day, total of 2 grams per kg. Continue to monitor parvo B19 PCR on a weekly basis. Welcome to the Medical University of South Carolina. There is no vaccine for hepatitis C. The only way to prevent this infection is to lessen your risk of coming in contact with hepatitis C virus. In this video, I'm going to share with you some tips that may prevent the spread of hepatitis C virus. Make sure you wash your hands often with soap and water for at least 20 seconds. If soap and water are not available, use hand sanitizer. Cover any cuts or open sores on your skin to prevent spreading of hepatitis C virus. Avoid swimming or using hot tubs if you have open sores or wounds. Do not share toothbrushes, nail clippers, or razors. Do not share needles or syringes. Avoid handling blood or other body fluids without gloves or other protection. Avoid getting tattoos or body piercing in shops or other places that are not clean. Use a condom every time you have vaginal, oral, or anal sex. Be sure to use it correctly each time. Both females and males should wear condoms. Condoms should be kept in place from the beginning to the end of sexual activity. Latex condoms should be used if possible. These offer the best protection. Keep all follow-up visits as told by your healthcare provider. This is very important. You may need a follow-up visit every 6 to 12 months. Good morning, everyone. My name is Kareem Solomon, and today I'm going to talk about volume assessment pre, during, and post-transplant, stressing on some remarks I've been seeing during the past few years. ساعات إحنا المشكلة. What's that? It's an Arabic phrase meaning sometimes we are the problem. Stay tuned. So this is Dr. Semmelweis. He's a Hungarian physician who moved to Vienna and worked there as an OBGYN doctor in 2 clinics. At some point, there was an endemic called childbirth fever. Infants were born and die within 48 hours. No one was able to figure out what's going on. Physician kept doing autopsies in the middle of the night, trying to figure out what's going on, and delivering babies in the morning. And the cycle goes on and on and on. They do autopsies in the middle of the night, and babies die in the morning. All physicians there drifted their attention to invent treatment rather than finding the cause of the problem. Dr. Semmelweis came one day and claimed that physicians should wash their hands appropriately to end this endemic, and no one listened to him. They called him stupid, they called him idiot, and at the end they fired him from the hospital or from the clinic. He went back to Vienna and noticed the same thing. He claimed the same thing, and no one believed him till he died from sepsis at the age of 47, probably from the same cause. At that time, a very famous physician, at that time he adopted Dr. Semmelweis' idea and theory and started implementing hand washing. And guess what? The endemic vanished. They named the university in Hungary after his name, Dr. Semmelweis Reflex. What's the moral of this story? Sometimes we are the problem. Sometimes we drift our attention to some things and totally ignore other things. As I said, our lecture will focus on volume assessment pre, during, and post-transplant. And here are the 3 stages. Talking about the pre-side, how many meetings did we go through discussing who should get a left heart cath? Hundreds? We even created a smart phrase, who should get a left heart cath? Makes sense, right? Our cardiovascular mortality has been increasing and we drifted our attention to pre-transplant workup. Who should get a left heart cath? I think hundreds of meetings, hundreds of hours, right? Which is totally fine. What if I told you that most guidelines, including KDIGO, I always say KDIGO when there is a court, what does KDIGO say, right? KDIGO guidelines. They say that routine prophylactic revascularization or angiography is not recommended in patients with severe coronary artery disease who are asymptomatic with good functional capacity and a negative stress test. They even don't recommend a stress test in patients with mild coronary artery disease. They also say there is no evidence that angiography is required in asymptomatic coronary artery disease patients with a negative stress test. And this is because transplant is a moderate risk operation and no major cardiac complications is anticipated or should be anticipated. Surprise, right? Talking about some of the left heart cath complications, this is a patient who developed cholesterol embolism in his toes after a left heart cath. And this is another patient who was considered ESRD, end-stage renal disease, on dialysis for 6 months, and he was making about 1 liter of urine daily. You decided to do a left heart cath for him, and his residual kidney functions are gone. So you killed his remaining urine output. He became anuric. So from the theoretical contrast-induced nephropathy. That urine output was helping him in between the sessions to drink more fluids. However, sometimes we are the problem. So let's highlight or focus on some other things now on post-transplant care. What I mean by post-transplant care here is fluid management mainly. So we'll focus only on fluid management here. Again, reiterating the fact the way we see the problem is the problem. Before we go deep into the subject, this is a diagram showing the US healthcare expenditure per capita. It was $2.3 trillion in 2017 and $3.1 trillion in 2020. So we have the highest healthcare expenditure compared to any other country. And despite that, we still have fatal, missed, potentially preventable errors. Let me give you an example of this missed or type 2 error. This is a 54-year-old male status post liver transplant 8 days ago. He has increasing static tremors, abdomen is not rigid, and urine output started to drop to 20 cc per hour. Serum creatinine went up from 1.2 to 2.1 to 2.6 and 3.1. FK level is 8.2, and it was 4 a few days ago. His serum albumin is 1.5, and UA is unremarkable. Transplant nephrology was consulted for kidney biopsy or possibly dialysis. So what's the most likely cause of his kidney injury? So it's probably not GN because the UA is bland or unremarkable, and likely also not intra-abdominal hypertension because the abdomen is not rigid. So what's left? FK toxicity. Hey, but the FK level is therapeutic, it's 8.2. How? If you don't know the pharmacodynamics of FK, you will mishear the diagnosis. And let me tell you why. FK is carried mostly on RBCs, about 90 to 95%. That's why it's called tacrolimus whole blood, right? 3 to 4% is carried on protein and albumin, and 1 to 2% is the free portion. So toxicity stems from the free and carried portion. So the free one, it's not carried on the red blood cells, it's not carried on the protein or albumin. So this 8.2 that you see here, it's a surrogate marker of the free portion that causes actually the toxicity. So if you have a low albumin, the free portion is high. And this high part, that causes the toxicity. Apart from the neurotoxicity we saw, the tremors, this is vasoconstriction or afferent vasoconstriction of the kidneys, decreases blood supply to the kidney, pre-renal element, acute kidney injury, elevation of creatinine. And here you don't know what's going on. I mean, FK is therapeutic, it's 8.2. However, the free portion is very high. Again, if we don't know this small info, we will fall into misdiagnosis. We're not aware of the problem, so we either dialyze the patient or pursue a kidney biopsy. And that's exactly what the US healthcare system is trying to avoid, misdiagnosis and avoiding expensive workup that's unnecessary. So understand volume status. This is a 54-year-old male status post liver transplant 8 days ago. Blood pressure is 99/70 and the CVP is 6. He has ascites, pleural effusion, and bilateral lower extremity edema. What's the patient's volume? So what's the patient's volume status? Is he hypervolemic, hypovolemic, dehydrated, or intravascular volume depleted but hypervolemic? So answer is C. So he's intravascular volume depleted because the blood pressure is marginally low and the CVP is on the lower side. However, he's hypervolemic. He has lots of fluids inside him, the ascites, the pleural effusion. So you cannot say here he's hypovolemic despite that the blood pressure is low. And you cannot say dehydrated because dehydrated is a water issue more than total volume issue. Got it? Another example to understand volume status. This is a 67-year-old female patient on PD for 4 years, called in for a deceased donor kidney transplant. On arrival, patient reports her dry weight to be 78 kgs. She has mild dyspnea on exertion. Blood pressure is 154/92, and she's on 2 blood pressure medications. She does not have any lower extremity edema, chest is clear, and the BNP, beta natriuretic peptide, is 110, or maybe 590, whatever. What's the volume status of this patient? Is she hypervolemic or hypovolemic? By exam, apart from blood pressure, there is no edema and chest is clear. Some people can say she's euvolemic. So the most common cause of high blood pressure in PD patients is volume overload. That's because your blood vessel can accommodate up to 5 liters inside before manifesting with edema or pleural effusion. So this patient is probably hypervolemic, and some people call it occult hypervolemia. So blood pressure is high, they're in 2 blood pressure medications. If you remove more fluids or give them Lasix if they're still making urine, they might reach euvolemia, but at this point, probably she's hypervolemic. And just a quick note regarding the beta natriuretic peptide, usually less than 100 excludes congestive heart failure, More than 500 is usually specific for heart failure. Between 100 and 500 is sensitive, suggestive of heart failure, congestive heart failure, but not confirmatory. And I'll come to this later. Here, I want you to understand the dry weight. So the dry weight is often inaccurate. It's not true. It's really, really very subjective according to who's the nephrologist who decides what's the dry weight or determines the dry weight. It's very challenging. And it's very complicated. So let me give you a story. A 25-year-old male, end-stage renal disease, secondary FSGS. He comes in with a blood pressure of 180/100 on 2 blood pressure medications. So the nephrologist starts to pull some fluids in order to reach his dry weight. So he pulls fluid one day until the patient feels cramping. So he said, okay, stop pulling fluids now. This is your dry weight. He ended up with a blood pressure of 160 on 2 blood pressure medication. Okay, what's your dry weight? Is 70 kgs. Another nephrologist comes and then says, oh, this patient has a high blood pressure of 160. He's still on 2 blood pressure medication. Yeah, but this patient cramped last session. No problem. Just remove more fluids. Let him cramp more. Every session, you start challenging your dry weight, removing extra fluid every time until he cramps, and you can do this 6-7 times. Believe it or not, you can remove like 6-7 kgs more out of him, end up with only 1 blood pressure medication, and his blood pressure is like 130/80. Who decided what's the dry weight? It's either the nurse there or the nephrologist. The first one determined the blood pressure, that the dry weight is 70 kgs on 2 blood pressure medication and his blood pressure is 170. Another nephrologist determined that his dry weight is 64 or something, 6 or 7 kgs less, with a blood pressure of 120 or 130/80 on only 1 blood pressure medication. See the difference? And in this spectrum, you can find different opinions and different dry weights and where it lands. That's why I don't trust dry weights coming from the patient or from the center. I've seen that many times. You can challenge their dry weight, like removing every time they cramp, and you squeeze more, every time they cramp and you squeeze more until you reach the actual dry weight. So in pre-transplant workup or for pre-transplant coordinators, what worries you? So there are different scenarios, bunch of scenarios. The first scenario is say blood pressure drop on hemodialysis. Sometimes people freak out from this. So if you have a young age, like a 25-year-old, he was a fresh start on dialysis and he's on 2-3 antihypertensive medications and their blood pressure drop on dialysis. Are you concerned with that scenario? I'm not. He's young. He just started dialysis. Probably he's hypervolemic on blood pressure medication and you pull fluids. I mean, he will drop. And this drop in blood pressure is not something to be concerned of. Another patient with high blood pressure before HD on antihypertensive medicine, and he drops on dialysis. Are you concerned? Again, I'm not. Low blood pressure before HD, he's on Metadrine, diabetic for a long time, and cardiac. Yeah, that might concern me a little bit. The last scenario, low blood pressure before HD, and he's tachycardic, and the blood pressure drops even more on HD. What's that? That's pericardial effusion. That's very important. And sometimes if it's tamponading, this is an emergency. They have fluid around the heart, so that causes tachycardia. When you remove fluid, you collapse the chambers of the heart. And that's very important. And some people don't recognize that. So the patient is like hypervolemic on exam. They have fluid inside the heart. You try pull fluids and the patient might collapse. So this is a very important clinical point. So blood pressure elevation on HD. Several causes. One of them is renin-driven. And what's renin? Renin is a protein or protease secreted by the kidney. Bottom line, when the blood pressure drops, patient developed hypovolemia. When you remove some extra fluid, the renin will go up in order to vasoconstrict the vessels in order to maintain this blood pressure. And while it does that, the blood pressure might go up, elevate, and it causes high blood pressure, hypertension. Also, when you use high sodium on the machine, when you use high sodium in the machine and the patient does not have a higher sodium compared to the machine, uh, the blood pressure will go up. One more thing, cool dialysate. If you contact yourself with cold water, um, same theory, the blood vessels will vasoconstrict, elevate your blood pressure. So many causes, but these are one of those causes. So some people freak out from the fact if a patient pulls a lot of fluids during HD sessions. Actually, that's not necessarily true. So if a young patient pulls 3 to 4 liters, for example, in between during the session, and he's young, blood pressure does not drop, and he's anuric, is that concerning? I'm not very concerned about this. For example, if you use a high sodium bath, that's your problem, your fault. You're creating iatrogenic thirst. The patient will come out of the dialysis and will drink like a horse. So when you have to pull a lot of fluids from him. Again, he does not have any residual kidney functions. He's not peeing at all. Some people pee like a liter every day, so they already pee like 2 liters, and then you remove 2 liters. That's a total of 4 liters in between sessions that he gets rid of. If he's totally anuric, you have to pull all those 4 liters during the session. So that's another thing to be considered. So not all scenarios that too much ultrafiltration or too much fluids is really concerning. And about non-compliance, that's also a question mark. 2 questions here. Why do we left heart cath a long-standing diabetic? This is the first question. Well, diabetes is the most common cause of cardiovascular disease and end-stage renal disease. Also, cardiovascular disease, one of the most common causes of death in end-stage kidney disease. If someone is diabetic more than 20 years on insulin and uncontrolled, probably they have lots of microvascular complications and microvascular complications affecting the coronaries, so sometimes they're occluded. Not talking about all the reactive oxygen species, hypertriglyceridemia, all the diabetic complications. So it's one of the most common cause of cardiovascular disease. That's why we sometimes do the prophylactic, although it's against KDIGO guidelines, but we do prophylactic just to make sure that the patient does not have something to be corrected. So the second question is, can you transplant a high-risk cardiac patient? So here where we say nephrology kicks in, right? So this is an email I sent out. Probably some of you got it before. So a patient was a long-standing diabetic, and some people said that there is no risk, particularly cardiologists, because the patient is asymptomatic. One very important thing is diabetics are usually asymptomatic in terms of cardiac-wise because they have diabetic neuropathy. So they develop something called painless or silent myocardial infarction, and they can pass into arrest without noticing any problems at all, and they don't have the typical chest pain of angina. So my recommendation at that time, if we want to proceed with a high-risk cardiac patient, avoid excessive fluids. You have to do it really under strict CVP guidance. Usually we prefer CVP to be like 12 at the time of anastomosis. You do CC by CC replacement for 24 to 36 hours, depending on the urine output and creatinine trend, and then drop to 75%. Be very cautious with fluid overload in these patients. So with the 75%, you include also the PO. Keep blood pressure around 120 over 140 over 70 over 90, and forget, please, about this permissive hypertension, letting the patient be discharged at 150, 160. Very small boluses you can give if the blood pressure is less than 110 over 70, not when the urine output drops. Keep the hemoglobin around 8, and you can give Lasix PRN depending on the clinical assessment and blood pressure. So if the blood pressure is high and the patient starts to develop a little bit of oliguria, you can push with Lasix. You can get an echo, heart, continue monitoring the blood pressure, and maybe a BNP before surgery. These are just some thoughts. By the way, you don't trend BNP inside the hospital. Moving on to the OR in kidney transplant patient. During the kidney transplant operation, what volume status do you prefer? You want them euvolemic with a CVP 8 to 10, slightly hypervolemic with a CVP 12 to 15, or slightly hypovolemic with a CVP 6 to 8. So usually you prefer them slightly hypervolemic with a CVP 12 to 15 in order to be sure that the kidney has a lot of blood supply at the time of anastomosis. So flush the kidney well. And you don't want to risk any more further hypotension or decreased blood supply to the kidney. So this is maybe the only situation where you really like that the kidney has much fluids and the patient is a little bit on the higher side. Problem is here when the patient comes originally with a high CVP, like 18 or 19, and not manifested by lower extremity edema or pleural effusion or pulmonary edema. This is the tricky part where you look at blood pressure and some other things to determine hypervolemia. And I'm wondering here, do we measure central venous pressure or CVP here? No, right? We don't measure it. I personally prefer measuring it. Some centers do, some centers don't, but I think it's one of the very objective criteria of knowing the volume status of the patient, especially during anastomosis and right after that. Some pitfalls post-transplant. This is a 54-year-old male, status post-kidney transplant 2 days ago. His blood pressure is 160/90, weight is up 4 kgs. He received twice Lasix, 100 milligrams, 8 hours apart, one maybe at 7 or 8 a.m. and the other one at 3 or 4 p.m. Blood pressure dropped a little bit to 150/85, and at 11 p.m. his urine output started to drop to 40 cc per hour, and he's net positive 3 liters. You check the Foley catheter and it's not obstructed. So the RN paged the resident. What would you do? In that particular patient, the patient got fluid bolus because the urine output dropped with a high blood pressure. So they thought that might be volume loss or they don't have enough fluids inside them. So they gave the patient a fluid bolus. And guess what? GNN will run after us in the RCA meeting, right? The quality team. Who's GNN? Right. So we don't want to do that, right? So correct answer is give Lasix. Anyone knows why the urine output dropped? Because Lasix works only 6 hours. So if you give it in the morning, it will last 6 hours, and then give another dose, it will last again 6 hours. The patient is still volume up, still weight is up, still blood pressure is high. After 6 hours, it will wear off, and then the urine output starts to drop. So either leave him alone or give him another dose of Lasix. There is no problem with that. As long as the blood pressure is good and maintained, don't worry about Lasix at all. Another scenario, pitfalls post-transplant. A 76-year-old male with coronary artery disease, status post-kidney transplant 8 days ago. He developed severe diarrhea, blood pressure dropped to 110/60. He's alert, oriented, weight is down 2 kgs, and hemoglobin is 7.1 gram per deciliter. What should you avoid? Rapid IV fluid boluses. What if you give them 2 liters of normal saline and 1 unit of packed RBCs? What's the expectation? So he's 76, he has a coronary artery disease. However, blood pressure is maintained. I mean, it dropped a little bit, but maintained. He's alert, oriented, not in a hypovolemic shock. I mean, weight is down a little bit. So if you give boluses, what will happen? GNN will run after us in the RCA meeting, and the patient will end up in the ICU, either with an MI or with an AFib with RVR, right? So we don't want to do that. Another scenario, pitfalls pre-transplant. A 46-year-old male patient, status post-deceased donor kidney transplant post-operative day 2. He's positive 4 liters since admission, positive 4 kgs. Blood pressure is 160/95 and then started to develop oliguria. So this is a real scenario. The patient received 500 cc IV normal saline. Another 500 cc, he developed atrial stretch from intravascular volume overload, change in the atrium. Patient run into AFib with RVR. Because he's young, if he's old, he'll develop probably an MI. So what happened next? The patient, cardiology was consulted and the patient was started on diltiazem. So when you start the patient on diltiazem, antihypertensive medicine to do the rate control, patient will develop hypotension and he's originally volume overloaded, so you're unable to ultrafiltrate him. Potential FK toxicity, because diltiazem is like a cytochrome P450 inhibitor, so FK goes up. And then the patient might develop delayed graft function from the hypotension and from the volume overload. Volume overload is like a cardiorenal syndrome picture, and hypovolemia decrease blood supply to the kidney. Sometimes you gotta realize you are the problem. Just remember the $3.1 trillion spent on healthcare expenditure, and this is type of the misdiagnosis or the type 2 error. So wondering, some random boluses will cost us hundreds of meetings, RCA, root cause analysis meetings, and protocol changes. Let's do a left heart cath. When should we do a left heart cath? 2 years post-CABG, 3 years post-CABG, 5 years post-CABG, diabetic more than 20 years. And we're drifting our attention into one part and totally ignoring another major part. Some random boluses may cost us hundreds of extra left heart cath, hundreds and thousands of dollars in ICU, higher mortality because you're overloading them, and higher DGF rate from the congestion in the renal vein congestion, like the cardiorenal syndrome picture. So briefly, what's beta natriuretic peptide or BNP? BNP is a potential marker for volume overload, and it's often nonspecific. So very briefly and very broadly, when the volume goes up, you give more fluids, the myocardium of the heart gets stretched, BNP and ANP goes up, they decrease the aldosterone, the antidiuretic hormone, and the renin, promote the kidney to lose more fluids, more natriuresis, more sodium, and causes more vasodilatation, so the blood pressure goes down. So we use this as a surrogate marker. When the BNP goes up, that means that the heart is stretched and under stress, and that's why we use it like a surrogate marker for hypovolemia. So worth mentioning, don't be tricked by BNP. As we mentioned at the beginning, BNP less than 100 usually rules out heart failure, and BNP more than 500 is usually specific for heart failure. However, there are some pitfalls. BNP might increase in old age, in high blood pressure patients, in a female with end-stage kidney disease. So these 4 factors might falsely increase the BNP. There are some other factors that might decrease the BNP falsely. If someone is obese or on antihypertensive medicine, specifically those which improve the cardiac remodeling or decrease cardiac affection on the long run. So, pearls and fluid replacement. A 54-year-old male, status post-kidney transplant, post-op day 0. Blood pressure is 140/95, and he's getting cc by cc fluid replacement. What is the best IV fluid replacement you would give? LR, half normal saline plus or minus 1 amp of bicarb, normal saline, or D5W. What's the best fluid replacement you would give? LR? I think we do LR here, right? LR. So the best fluid replacement is half normal saline plus or minus bicarb. So what happens if we give LR or normal saline or replace the urine output with normal saline or LR? So let's sum it up. This is from the Handbook of Kidney Transplantation. At time of anastomosis, as we said, you prefer that the patient is 1 kg above their dry weight, and that's supposedly that you know their dry weight, their actual dry weight. And then you replace usually the urine sodium concentration just after post-operative period in a DGF or an ATN kidney. At the beginning is usually 60 to 80 milliequivalents per liter. So you have to replace the same amount, 60 to 80 milliequivalents per liter, in order to not overload the patient. Can you imagine if you give them a solution with 130 or 135 or 154 sodium, you give them the double amount of sodium, you develop more hypertension, high blood pressure, and you, guess what, volume overload them because water follows sodium, right? When necessary, you give potassium, bicarb, calcium replacement. Some people do the insensible loss. I don't prefer it because it's more, you drive them more into hypervolemia. They give 30 ml per hour, but per experience of what I've seen, you drive the patient more into hypervolemia. So this is IV fluid replacement pearls, and probably you know that better than me. Usually our plasma has 135 to 145 sodium. That's the concentration, and the osmolarity is 291. If you give normal saline, it's 154 content of sodium, and LR, what we give here, is 130. So you're giving double the amount the kidney is getting rid of or dumping out. As we said, you promote hypervolemia, you increase or aggravate the hypervolemia, you aggravate the hypertension. So sometimes the patient comes out of the OR with a blood pressure 140, 150. A day later, they're 170, and you start giving medications. You start giving antihypertensive, and you totally ignore the fact that the patient is hypervolemic, and all they need is just correct the IV fluids, stop the IV fluids, or give Lasix. By the way, hypervolemia, again, leads to DGF and leads to coronary artery disease, AFib, and all these complications. Drift our attention towards post-transplant care. So this scenario really makes me cry post-kidney transplant. So, for example, post-op day 0, a patient is 80 kgs. His blood pressure is 140 over 80. Post-op day 1, you give them fluids, double the amount of sodium, cc by cc replacement, plus the 30 ml per hour. Patient slowly, weight goes up to 80 kgs, blood pressure slowly goes up to 150 over 85. Slowly, weight increases to 84 kgs with a blood pressure 154 over 89. And here, instead of giving Lasix and stopping IV fluids and get rid of this fluid that's causing hypervolemia and intravascular volume overload, you start them on antihypertensive medicine. Once you start them on antihypertensive medicine, there is more room, the blood pressure drops, so you give more fluids. So the patient gains more 3 kgs, so they end up with 87 kgs with a blood pressure of 151 over 87, and they're positive 7 liters. Guess what? You discharge them at 90 kgs body weight, with a blood pressure of 162 over 92, positive 10 liters. Urine outputs start to decrease, and the patient develop azotemia. And then comes to the clinic, you mark them or label them at DGF and ask transplant nephrology to dialyze them. So what's the difference between azotemia and uremia? Anyone knows? Azotemia is a BUN, high BUN, okay? So high BUN in lab, there is no uremic manifestations, no uremic encephalopathy, no uremic pericarditis, nothing clinical-wise. That's considered azotemia. Uremia, you're adding the clinical, any clinical scenario, confusion, flappy tremors, all this. So honestly, when the patient is discharged like this is how I look, because I'm a consult service. So this is how I look, and I hear the kidney crying and screaming for help. Yeah, exactly. So in this particular scenario, the kidney screams, "Don't suffocate me." When you give IV fluids, you increase the preload on the heart. And when you increase the preload on the heart, you increase the hypervolemia, increase the load on the heart. At the same time, you cause renal vein congestion. What's renal vein congestion? Blood is coming into the kidney, but not able to come out of the kidney. You suffocate the kidney, or you clog the kidney. You increase the rate of DGF. And that's exactly, you know how the toilet gets clogged? That's exactly what happens. The toilet gets clogged. So you're clogging the kidney, and then you say the kidney is not working, and then you call for dialysis. And that's, again, a missed diagnosis or type 2 error. If we discharge them on a really euvolemic status, we could avoid a lot of complications. And this is a summary of hemodynamic assessment post-kidney transplant. So the patient is oliguric. If the patient is oliguric, ideally look at the CVP, blood pressure, edema, and BNP. If they're hypovolemic, you can give only 250 to 300 normal saline challenge. Normal saline is a good IV fluid replacement to elevate the blood pressure. However, if they're U or hypovolemic, you just look at the Foley catheter first. They're persistent oliguria, despite both scenarios. You do an ultrasound with Doppler or renal scan, especially if the patient hemoglobin drops a little bit. If you find no flow in the kidney, you consider surgical exploration. If there is a good flow in the kidney, that might be a DGF scenario. So this is a very broad scheme that you approach when you find those scenarios. So let me ask you, why did I target RNs here with this lecture? Do you guys get this email at 4 a.m. in the morning? I love it, by the way. I read it all the time because you guys are the safety heroes. Look here. She alerted the provider and advocated for the patient. You guys are the safety heroes. Providers love feedback. If you find something that's sounds not appropriate, sounds incorrect, just alert the provider. And again, no hard feelings. We're working all to the best interest of the patient, right? So finally, those who understand shall alert others, spread the knowledge, and do no harm. Thank you so much. And I welcome any questions. Yes.
Hello.
Yes, we hear you.
Can somebody hear me?
Yeah, we hear you.
Yeah, Karim, phenomenal cartoons. Thank you.
You didn't see from the beginning, Ro.
I saw it from the beginning. It was so good. No, I can't take my eyes off the slides. No, seriously, great presentation. Hey, a quick thing. As we said, we have had this conversation maybe 100 times so far in the last few years, and I totally agree with you. We need to tweak a lot of few things. Interesting thing. One of the things about the post-operative fluids. Okay, it's. I just wanted to give you the whole thing, how things have changed over a period of time. So when I was a fellow here 10 years back, our regular fluid replacement was half normal saline. I think that was the right replacement because we used to give plus or minus bicarb depending on the bicarb with half normal. And if the sodium goes up, goes down also, we used to like add a little bit of bicarb to that, and then you will correct the sodium. Then apparently, like when I left as a fellow and came back, we had switched over to normal saline because somebody did not follow the sodium, somebody became hyponatremic, had some went to the ICU, there was a root cause, something like that. I heard the rumor because I don't know, I was not here. So when I come back, it is down to normal saline. Normal saline is the worst of all three, as you know, because highest amount of sodium, most acidotic fluid. Then we switched to LR because the institution has been pushing to make LR as a replacement fluid as opposed to normal saline, because there are a couple of papers which came out, not in transplant patients. This was, most of them are ER patients and ICU patients. Study was done in Vanderbilt. They compared normal saline to Ringer lactate. So I personally think for our patients, these are all, and not just personally, scientifically too, wrong fluids. Half normal with the ampoule of bicarb is like the perfect fluid. That's what we used to do in when I was in Pittsburgh. That's what the fluid was. I mean, they used to even manufacture the right kind of fluid where 5% dextrose with bicarb with something, and basically try to make it as so-called physiologic as possible. So issue here is, I'm totally, I think one should be doing that too. But one of these are the things I want to discuss in the retreat. If we can have like a couple of slides regarding the fluids with the couple of awesome cartoons, which will have the message, because issue is, hey, what is the difficulty for pharmacy to getting this fluid? Can we do this for all the patients? All those things. That's because we can have a slightly more robust discussion with a bigger audience for that.
Thanks, Ro. I totally agree with you that there are a couple of papers coming back that they say that the normal saline actually might cause AKI or delay the recovery of AKI, but this is native kidney number one, and this is not DGF ATN kidney. It could be like a GN kidney post contrast. By the way, pre and post contrast data previously they used to give normal saline. I prefer half normal plus 75 because bicarb, again, I think bicarb is great for the kidney. The kidney loves the bicarb, honestly, loves. And there are tons of articles that they say bicarb per se in chronic kidney disease delays the progression of kidney failure. I mean, and if you follow that, but I totally agree with you. But for this type of thing, and you know that, and you agree, this type of DGF, all the guidelines have normal, plus or minus, and replete. And even if they develop hyponatremia, that's why the nephrologist is on board. I mean, dump the trash on him, you know?
Yeah, no, and
other people.
no, so the problem previously was people just did half normal. I mean, bicarb. I mean, obviously, I was not here when we changed from half normal to normal. Yeah. That was in those 3 years. When it changed, I'm sure it happened because nobody was following this patient enough to change the fluid when the sodium started dropping to, say, 129. Nobody looked at it at 129, and before you know it is 120, something like that. So it is not the fluid which is the problem. It is people did not follow up, simple as that. And people were pounding the patient with fluids, basically free water.
The huge problem is they always say Lasix and salt do not work. So you're just don't drink and drive, you know? If you give Lasix for someone who's like on high salt intake, you're practically giving nothing. It's like giving EPO, erythropoietin, with a low iron. So you're stimulating the bone marrow to form like more blood, and you don't have the supply to form the blood. I mean, stimulate to form carbs, and you don't have metal or iron or whatever. So it's the same thing. If you give Lasix with a high normal saline, the blood pressure still remains elevated, and you might not get the maximum benefit of it. But yeah, you're right. So these are a couple of thoughts I just had from like observation. We talked together several times, bro, about this. Like we had tons of discussion. Yeah.
Yeah, no, love this. And I love the last twitching tail of the kidney. It's beautiful.
Yeah. Christy had a question.
Thanks, man. Thanks a lot. Yeah.
Thanks, bro. Thanks for coming.
So I'm trying to find the email from him. They basically are really concerned about the nursing load on 8 hours and 24 hours. Do you think that you could explain kind of why that change is made and why it's so important?
Was it me? So what do we do now?
So now it's 48 hours.
It should be 24 hours, number one. It should be 24 hours. And actually, so to be honest with you, it should be depending on creatinine trend, okay? But 24 hours is great. And usually what I do, 24 hours to 36 maximum, and then I drop all of a sudden to 75. Why? Because if the kidney is making 5 liters per day, okay, assuming living kidney donor making like 10 liters per day, 5 liters per day, and you give 100 cc per like a cc per cc for 48 hours, you delay actually the recovery of the kidney, the ATN recovery. So if you replace for 24 hours only and then drop PO plus, I mean, whenever they start PO plus IV to 75 together, as long as the blood pressure does not drop, is hypovolemic, as long as that like put under this like 100 lines, the blood pressure is good. I'm with 75, PO plus IV together, 75. You have to wean the kidney quickly and make the kidney work. So 24 hours, CC by CC, why some living kidney donors can make up to 20 liters per day, okay? And if you do 75, they will run into hypovolemia real quick. And that's why some people give the 30 cc insensible loss. I don't think there is 30 cc insensible loss at all in our, it just does not happen. But they give it to be on the safe side. And that's why the patient, some guidelines say, the patient is making more than 15 liters per urine, they sometimes safety their back and give another 200 extra, because they fear. I saw one patient before, like 10 years ago or something. He was a transplant patient post-op day 1. He was making like 10 liters per day. The nurse is checking the CVP, and CVP was like 10 consistently. And then the patient tanked. Blood pressure drops, CVP is 10, and the patient died. Post-op day 1 or 2. Why? CVP was obstructed, or just the neck is like, and he was like measuring as a 10. What's the first sign to appear in patient who's losing fluid or is hypovolemic or intravascular volume depleted? What's the first sign? Make it easier. Tachycardia, and then hypovolemic. So shock. He's going into shock. Tachycardia is right. Totally right. Number 2. Hypotension. Postural hypotension. So blood pressure is maintained, but when they stand up, they develop orthostatic hypotension. That's the second sign. Third sign is frank hypotension. Hemoglobin, by the way, takes some time to drop. So if he's 7 and he's bleeding, if you follow in an hour or 2, it might be still 7 or 6.9, but it drops then all of a sudden after a while. So tachycardia is very important. Exactly volume, by the way. So sometimes you round on the ICU and you listen to the patient at the basis and you say chest is clear. 12 hours later, they develop frank pulmonary edema, or sometimes we go, I mean, in the ICU, the patient looks not hypervolemic, just give him some bolus and he develops frank pulmonary edema. Because the lungs, when they accumulate fluid at the beginning, they accumulate in the basis and you hear these crackles or crepitations, you have to hear them at the end of inspiration. Because if you hear them just normally like this, you will not hear anything. So you tell them, take a deep breath. So at the end of the deep breath, you're like crackles at the end. That means he's starting to develop impeding pulmonary edema or pulmonary congestion. That's why they stress on this a lot. All the board questions, everything, they stress on this a lot. If you find a patient by exam a little bit of clinically overloaded, what would you do? Do a BNP chest X-ray or do nothing? It's do nothing because it's a clinical diagnosis. Why should you do workup, further workup, and spend more? And you might actually miss a diagnosis. If it's a very early pulmonary edema, you might miss it. And 12 hours later, they might run into pulmonary edema, actually. The main things, again, fluid is very important. The other thing is also I see a lot is the albumin part. Albumin, again, put that in mind. If you look at the 8 FK level, this is not the level that causes the toxicity. It's the free portion which is carried on albumin. If you have albumin low, you have a higher free portion, vasoconstriction on the kidney, and tremors. The other thing is, and this is the art of transplant, not every patient should be on FK 10 during the first 6 months. I mean, I don't want to play into protocols and stuff like that, but the thing is, if you have someone living related donor, and I mean, a great match, no DSAs before or negative cross match, everything, and very low risk of rejection, it's acceptable to keep it on a little bit of FKY. Apart from FK causing vasoconstriction during the day, so if you check a creatinine in the morning, it could be 6 with a level of 7 or 8. And if you check the creatinine at noon or afternoon, you might find the creatinine of 1.3 actually, but we don't do that. So if you measure that hand in hand, because it's vasoconstriction and goes with FK, I mean hand in hand. So it causes vasoconstriction, intermittent AKIs that's unnoticeable. Number 2, FK on the long run causes something called fibrosis in the kidney. It increases the TGF beta, like something that causes fibrosis in the kidney. So on the long run, it causes chronicity. So why FK? Because it's a backbone. I mean, it's a very important, extremely important immunosuppressant, very important. But extremely important immunosuppression. And there are a couple of, lots of papers and evidence. If you have FK, fibrosis damages the kidney less than rejection. Rejection kills the kidney in a second, exactly like BK. If you have BK or rejection, treat rejection, don't care about the BK now. Rejection kills the kidney in a very short time. But the thing is, you gotta be cautious when you play with immunosuppression, really cautious. Rejection is possible, yes. AKIs are possible, yes, but we walk on eggshells, it's an art. And that's why we try to develop protocol, but you can never protocolize everything, never. Any questions? Questions?
Sorry, I found it. The challenge with the FT 1 hour urine output for 48 hours as well.
So it's
in their current situation.
to be honest with you, it's 24 hours, okay, and then drop to 70. Once they take PO, just leave them. If the blood pressure is great, leave them and they. I think when I talked to Bro, it was mainly because we used to give CC by CC an extra 30, and no matter what, and then flat rate them, and then they go up with 10 kgs up. Even now, I mean, if you give LR or normal saline, they will go up, no matter what, even if you give Lasix. Like a month ago, I came on service, a patient blood pressure consistently 200 over 100. She's on 4 blood pressure medication consistently 200 over 100. We're replacing with LR, stopping everything consistently. You cannot treat resistant hypertension without a diuretic, as if you're like a baby pushing a gorilla. You cannot. Part of the definition of resistant hypertension, it's resistant with 3 or more blood pressure medication, including a diuretic. Diuretic is very important. So get rid of the diuretic, give normal fluids, and look at the outcomes. Left heart cath. Who needs a left heart cath? There is no guideline that says anybody needs a heart cath, honestly. They say anybody walking in the street, if they have more than 4 mets, functional capacity is good, just do the transplant. It should be a very mild to moderate risk of operation. It's not a big risk. You just put a kidney. I mean, when I'm talking to Warren, it's like an appendix, removing an appendix.
I have a question along those lines. You're saying that not everyone needs a heart cath, and from my understanding, you have a poor outcome related to heart issues post-treatment. So is there some other aspect that we're managing, or if we did need a cath patients, then how are we going to cut?
We're focusing on one thing, and that's right. I mean, there's no problem, but I'm telling you, if someone had a cath right before transplant, 6 months before transplant, and they had a 40% obstruction, and we're giving them this amount of fluid, if you give me this amount of fluid, I could collapse, by the way. I mean, everybody. I mean, it's a balloon, okay? And you fill this balloon with fluids. It might rupture. I mean, and then when you fill all this fluids, you will develop ischemia. So the 40% will go up to 80%, 90%, and then blockage, okay? And then when you do an autopsy, you find a blockage of 90% of 100%. Oh, that patient should need a heart cath before. We missed the left heart cath before. If you did the left heart cath before, it may show like a 40%. Again, a left heart cath has problems. You damage the residual kidney functions. I always tell patients, do you make urine? Some of you might have seen this. I sometimes like to do like a CT with contrast for patients who are really resistant hypertension or whatever to rule back anything. Sometimes you want to do the contrast, okay? I asked the patient, do you still make urine? I've been on dialysis for a year and I still make urine and I have a residual kidney functions. I'm very skeptical of giving them a contrast because the kidney has 2 functions, getting rid of the fluids, which is very important and it will help post-transplant, and getting rid of the toxins. That might be the compromise. What are we doing? What might improve? Changing the fluids, keep them euvolemic, assess the volume status right and correctly. You cannot have a patient coming in with a blood pressure 150, you assume they're euvolemic because there is no edema, and you give them the OR 4 liter positive. They come out of the OR with a 4 liter positive and then replete them with 130%, 130% or whatever, or 1 cc by cc and extra 30, avoid Lasix, blood pressure goes up, you give antihypertensive to vasodilate, and then the patient comes in 10 kgs. Believe it or not, a young age can accommodate in their vessel up to 5 liters. So it will expand. I mean, the arteries are still expansible, but in old age, they won't tolerate. They would develop easy MI or AFib with RVR. Easy. Honestly, I've seen patients with a heart, like so-and-so heart, 79-year-old, and they got transplanted and totally fine. It needs really very cautious follow-up, very cautious fluids, but they pass well. And they did not have a left heart cath before. It's fine. I'm not saying left heart cath is bad or